should unmute yourself. Okay, so good morning and good afternoon, everyone. I'm Shalini Jaishekhar-Zyun, and I'm a Senior Advocacy Manager with the Union for International Cancer Control. And it gives me great pleasure to welcome you to the Special Focus Dialogue in collaboration with ICONIC on Prehabilitation, where we will share experiences in developing, implementing, and evaluating prehabilitation interventions. Before we start, I would like to take a moment and remind everyone of a few housekeeping rules. Please do mute your microphones when you are not speaking. And also please use the chat box for any questions to the panelists. And you can also ask questions by raising your hand during the Q&A session. And I'd also just like to point out that this session will be recorded and available on the UICC platform very shortly, within a few days actually. And now I'd like to hand the session over to Dr. Steve Wooten, who is Associate Professor of Nutrition with the University of Southampton and the chair of this session. It's over to you, Steve.
Thank you very much, Shalini. It's lovely to be here and to join all our friends and colleagues across the globe. Today's Special Focus Dialogue is very much around sharing our thinking, sharing our experience, so that we can better understand how to care for patients before, during, and after their treatment. Just by way of introduction to ICONIC, because many of you may not be familiar with ICONIC. ICONIC, the International Collaboration on Nutrition in Relation to Cancer, is a task force of the International Union of Nutrition Sciences, and it seeks to build collaborations between those responsible bodies involved in nutrition and cancer at the international level, with really the ambition of trying to bring leadership, coherence, and focus to what we're already doing and stimulating new ideas. We aim to build capacity, promote research in order to improve care and outcomes for those affected by cancer. So today's session is very much about prehabilitation. This is a relatively new concept, and we'll talk about that in a bit more as we go through. But in essence, when receiving a diagnosis, people with cancer face so many challenges. For some, the cancer may already have affected their physical and nutritional state and their psychological well-being before treatment is started. Individually and collectively, such changes can decrease resilience to the cancer, resilience to their treatment, and affect their response to surgery and different forms of systemic anti-cancer treatments. Those of us involved in prehabilitation strongly believe that patients need to be provided with the necessary support to address their nutritional needs, to engage in supervised structured exercise therapy, and offer the essential psychological support and well-being to enable them to participate in their care. By intervening early in their care, from the outset, we believe that a patient's physical, psychological resilience and response to treatment can be improved to foster a sense of control, purpose, and enabling them to take the necessary steps to improve their nutrition and health in the long term. Today, we are very fortunate. We have three of the world's leading authorities, and I must say most passionate advocates for prehabilitation. And we've asked them to share their experience in developing, implementing, and evaluating prehabilitation in oncology. The first of our speakers is Franco Carli. Franco is Professor of Anesthesiology at McGill in Montreal. And to many, he's the godfather or grandfather of prehabilitation, having published many of the original studies, and with his team in McGill and his international collaborations has led much of the major trials in the area. He led to the founding of the International Prehabilitation Society. He's very involved in the American Perioperative Medicine and Evidence-Based Medicine Societies, and has really encouraged us all to consider how we might develop our research and our care. The second speaker is Stefan van Rooijen. Stefan is a general physician, or just completing his training as a general physician, and he conducted his PhD research in colorectal cancer surgery, introducing prehabilitation into the services, and working with others has been very instrumental in developing an international protocol for prehabilitation. At the moment, he's moving into primary care, and very much of in trying to make prehabilitation available to everyone, make it more sustainable, more accessible. And he'll tell you a little bit more about his interests and his work at the moment in creating the Dutch Fit for Surgery Network, a sustainable healthcare program in Holland. And finally, we have Sandy Jack. Sandy is, we think the first professor of prehabilitation medicine that we're aware of. And Sandy's here in the University of Southampton, where I'm based. She's also a consultant clinician scientist in anesthesia, critical care and perioperative medicine here in the hospital here. She's co-director of the Fit4 Consortium and very much brings a wealth of experience in leading and delivering prehabilitation in healthcare services across the various public sectors and community services. Each will offer their own perspective on prehab. I'll then pose some general questions and then we'll open the panel for Q&A. Please remember to post your questions during the presentations and we'll take them all there at the end. So without any more ado, Franco, would you like to offer your perspective on prehabilitation?
Well, good morning, everyone, and thank you very much for inviting me, Steve. You and I know for a long time, and it's a pleasure again to come up to this group and discuss a little bit about the concept of prehabilitation. So I just want to, I don't have any slides. The reason I didn't put any slides is because I think probably we can focus on what we're actually talking about. So imagine for a moment you have three persons at the moment. One is a marathon runner, one is a patient with cancer, and the other patient is a patient with cancer, and another patient is going for surgery. What do you think is the difference between the three individuals who are going through these three events? I believe that actually they go through the same stress. One is a physical stress, exercise stress, intense exercise stress, endurance stress, which takes hours, obviously. The second one is cancer, with a definitely physiological, nutritional, biochemical, inflammatory stress. And the third one is surgical stress. So physical, mental, nutritional. So there is a great similarity between these three. All have a major inflammatory response. Now, the question is, how do we deal at the moment with these three individuals? Now, the marathon runner, well, he knows that he's going to have a major and a stress in front of him, and he's preparing. He eats well, he rested, he may do meditation, yoga, he controls your body, he knows exactly each muscle, and he knows that he has to prepare for it, so he trains. The other two happen something involuntary, that they actually receive the news of cancer and receive the news of surgery, major surgery. What do they do at the moment? They are concerned about what is actually to their body. They are worried about their family. They are losing weight because the major surgery is imposing a stress on them. They probably sit down and they are thinking but do nothing. And they wait for the diagnosis, they wait for the next CT, MRI, the next visit, and maybe surgery, maybe chemotherapy, maybe radiotherapy, maybe nothing. So why I wanted to use this analogy is just to put you in front of you this concept of that Steve mentioned at the beginning. You're giving a diagnosis of cancer, you're giving diagnosis that you need a major stress, major surgery. Why we are not using this time to prepare ourselves in the same way as a marathon runner? The marathon runner will be succeeded in relation to what efforts he puts in. So let's concentrate for a moment. If we accepted this concept that intervening after surgery or after, once the cancer is already progressing, or is after chemotherapy, then I think we're catching up. So we want more a preventative, it's not preventive, obviously, it's a preventative measures. And this preventative measure, we should think about what are the elements. And we know that functional activity is very important for patients. There are beautiful studies just came out on adult surgery a few months ago, where they actually asked patients who had a surgery, they said, what is important for you when you recover? And definitely what is interesting, obviously, they want to go with friends. They want to go back to normal life, go to the bank, go to play bingo, go to see family. For the clinician, it's important whether they passed gas or they had a complication, or maybe there was an ileus or pain. But why don't we move more towards the centric aspect? What is important for the patients? And that's where the concept of functional capacity or activity, fitness comes in. So the data clearly have shown that if you start with a poor functional fitness, the outcome is poor. So that means delayed recovery, risk of complication, and so on. Well, I will put at this point also the malnutrition issue here. Because, unfortunately, in surgery, nutrition has been neglected. And now we're becoming more and more, and with cancer, obviously, becoming more and more aware of the importance of intervening as soon as possible in blocking this progression. And that's where I think this is a great meeting to some extent, because I think we should promote nutrition, but I think we should screen for malnutrition as soon as possible. So I think that the approach, in my view, should be that when a patient is diagnosed for cancer, it should be put in this prehabilitation concept, call it prehabilitation, preparation, optimization, where we not only look at from the medical point of view, we're treating, of course, we're treating hypertension, we're treating diabetes, we're treating anemia, and we're treating smoking cessation. But I think is this patient fit in terms of physical fitness? Is the patient nourished sufficiently enough? Because we know that all these elements, and also depression, anxiety, as we know, is very common in the patients waiting for surgery or with the cancer diagnosis. These all three elements independently are independent factors for postoperative poor outcome. So why don't we intervene before instead of intervening after? When after patients, of course, surgery are tired, after chemotherapy are exhausted, nobody is doing anything, they're isolated, they're waiting for what is the next step? Instead of empowering them and exercising an excellent form of empowerment. So I think at this point we have looked at the inflammatory response. We looked at, we should not approach after, but maybe before. My colleagues will discuss about. But when we come to surgery, we have to think about, can we reasonably start as soon as possible? When we look at the diagnosis, and can we look for the moment the surgeon diagnoses to the time patients arrive to surgery? We have always 4-6 weeks. That's a salient time that we can actually do it. So, but I want to finish. Rehabilitation is not something that I can do alone, or a surgeon can do alone, or any of you can do alone. This is a classic team approach. If you do team approach where you put a front line with you, not consultation, front line, that means that your kinesiologist or physiotherapist, your geriatricians, your nutritionist is with you discussing the patient immediately when you see them, I think that becomes the success, in my view, of prehabilitation, and not a ping pong where you send them to the different consultant and you're lost basically in communication and so on. And that's where the patient comes at the center. So I stop here because I'm sure my colleagues will go into details how you organize, implement, screen, and so on. Thank you.
Thank you, Franco. That's a wonderful introduction to the session today, and it really helps focus our mind on the patient and the patient's perspective. So thank you so much. Stefan, would you like to share with us your experience?
Of course. Thank you very much, organizing committee, to have me here today, and in special Professor Steve. It's always wonderful to have all these believers together, and I'm happy to share our experiences. So I hope to inspire you today how prehab can make patients and healthcare workers happier. And this is the first slide to introduce myself a little, but Steve already did. I started my professional career in 2015 on a bike together with surgeon Gerrit Sloeter, as you see here. And we created with two other surgeons, Emma Bruns and Boukje van den Heuvel, our Dutch Fit for Surgery Foundation, to share all the information we had from different hospitals on this topic. And in 2018, I finished my PhD showing the benefits of prehab for colorectal cancer patients in our country, based on a protocol that I wrote together with Professor Franco, because he was the one that inspired me in 2015 and made me a prehabilitation believer. And last year, I published a book available in the Dutch stores, unfortunately not in English yet, but with the goal to make prehabilitation and a healthy living understandable to the general public. And currently, I'm ending my GP practice. Just a few months left, and creating together with the other Dutch prehab believers a nationwide Fit for Surgery platform in primary care. And we start with this from January next year, where all the physiotherapists in the Netherlands can be trained from January on with the protocols that we all agreed on in our country. So we have the basic education available for everyone, making it having a bigger impact in our country. Next, please. So today I would like to inspire you on our prehab journey in the Netherlands, giving 4 reasons, and I will back it up with some numbers, show you the impact, the role of patients, and come up with a solution as well. Next, please. So looking at the numbers first, we have 10 million people in the Netherlands having 1 or more chronic diseases. And this is quite similar in other Western countries. As you see a quote here from a big newspaper in the UK, is that inactivity is an ongoing pandemic in the UK as well. 4 out of 10 adults in the UK are suffering from inactivity and chronic diseases as well. So I have bad news. We became couch potatoes. So where we needed to perform exercise to kill a mammoth in the past, we now ended in a position of chronic inactivity, and chronic diseases are everywhere. So speaking of inactivity in general, we do have a very bad starting position. And many of us start from a position of weakness due to this sedentary lifestyle. But what happens if you have an injury, or if you are forced to rest more than usual, or need to recover from surgery? And how long do those effects last? How can you minimize the side effects of immobilization and recover from injury? So for this, we need to know a little bit more where these chronic diseases come from. And that you will see on this slide. Bad numbers aren't just there. I think the next slide, please, with the numbers. So if we think about the origin, the environment plays a very important role. Why can we get everything that is so salty, too sweet, and too fat at every street corner? And why is 70% of what we sell in supermarkets unhealthy here in the Netherlands? And why do we work behind a desk, and why I'm sitting here as well for 40 hours a week? And why do prices for healthy food still increase more than unhealthy variants? So this environment and our health and our attitude causes these numbers. Next, please. We may also think how we ourselves can be part of the change. We may need a change in our mindset, a change in our system. Why do we usually put patients in a bed after entering the hospital? Well, they came in walking. It may not only be good for their activity and the immune system and recovery when moving their own beds, it may also change the attitude of us, health professionals, towards how we organize our healthcare. Expect your change in attitude as another window of opportunity and a trigger for change. You're the one that can build bridges and breaking through silo thinking. And prehabilitation and enhanced recovery after surgery are great examples how you can practically do so. Next, please. So enough about the numbers. We go because it's clear enough that we can and we have to change. But what in particular if you await surgery? Franco already addressed, and many of you will know the effects of surgical stress. So I'm not going into detail. I would just like to make you aware of these systemic effects. So surgical stress has a big impact on complications, the inflammatory response, and your recovery. Next, please. We have also done a study in colorectal cancer patients, which shows there is an increased risk of getting severe complications when you do have more risk factors preoperatively. And these risk factors appear to be almost all lifestyle related. Think of smoking, overweight, diabetes. And the good thing and news is that these risk factors are, at least many of them, modifiable, even in a short period of time. So we may be able to reduce risks before surgery, improving those lifestyle related risk factors. Next, please. And there prehabilitation came into reality. Our grandfather, Francesco Carli, created the idea to improve the functional capacity before surgery, enhancing the recovery after. Next, please, because there you will see the figure. And in this figure, you see the prehabilitation change and belief. So improving the functional capacity before surgery enhances the recovery after, making patients less care dependent after surgery. That's the main goal. So next to the introduction of ERAs, both prehab and ERAs together really made a difference. Next, please. And that's a huge difference. These studies of my thesis proved what many other worldwide studies also show in their pilot studies, that high intensity based and supervised training increases strength with up to 20% in just 4 weeks of training, the functional capacity with 15% in just these 4 weeks of training, lesser complications after surgery up to 65%. And as you can imagine, also lower the costs up to 1,200 euros per patient in our country. In the right figure, you see the earlier recovery 4 weeks after surgery of the prehab group compared to the control group. And that's a big difference, 86% versus only 40% of the patients that did not train. So although the impact of surgery is big, we are able to impact this by being more active and improve the lifestyle related factors before surgery. Next, please. So now we know the numbers and the impact of surgery. What do our patients say and how fit are they? This is Dineke, one of my favorite patients that did undergo our prehabilitation program. And she was double unlucky since she was diagnosed with both a TIA and by catch colorectal cancer. She wasn't living healthy before because she didn't exercise much. And by explaining the potential of prehab, she felt that this would be an opportunity to her to get back charge of their own body and her own treatment. And here she smiles. This is a video and part of it. After the uncomplicated surgery and after 1,000 kilometers on her bike, just a few months after surgery. So prehab in our experience, really makes patients happy as long as you understand them well about what it means. Next, please. And we do need fit patients. This is a slide we use to share a lot. It shows the metabolic equivalent, which explains us something about the functional capacity and the fitness of our patients. And as you do see here, our worldwide champions are fittest players. Think of Messi or Ronaldo with MET scores around 20. We as average people around the table score half of that, and a patient with colorectal cancer even half of that again. So that matters since we know that a reduction of just one MET increases mortality with 15%. So that's a huge impact. Next, please. And not only this physical starting position matters, also what goals patients have. There's usually a big gap in between what patients want and how we think we can offer best support. So I'm asking you, have you asked your patients how they would like to be supported best? Patients usually emphasize their energy level or how to get back to their functional capacity to be able to perform their daily routine. Doing groceries, etc. And professionals think more about organ and treatment-related problems. So there's also an improvement possible to think in the needs of patients. Next, please. We go to my fourth and last point. Because getting active is how you can make impact. And I believe that becoming a believer and think along with our Prehab family can help in this. When you believe the benefits of being active, it will also be easier to convince patients to embrace lifestyle improvement as part of the treatment. So if you feel like moving now, you can just start moving, because with this long talk, you feel more inactive and you know the complications now. So if you want to move, please move and feel convinced that this really helps. So just take a moment, enjoy this snack-exercise, how we call it in the Netherlands. And you may feel energetic soon. I see Professor Franco already feeling more active. Great. So next, please. Prehabilitation is, in my belief, a very welcome solution to challenge inactivity and a bad lifestyle before surgery. But still, not the whole world started implementing. So how can we make sure Prehab will soon be available for everyone worldwide? And I think part of that solution is knowing why Prehab is so complex. It's a great example of integrated value-based health. And implementing this prehabilitation program is complex in both width and height. And I tried to explain it in this figure because prehabilitation needs a collaboration between many healthcare professionals, knowing about behavior change, exercise, mental support, etc. But that doesn't make you implementing prehab easily by being convinced as a healthcare professional. You also need your medical board, the insurance companies, people from the industry to support you with applications, etc. So it's a very complex intervention that needs a lot of people to work together and to build bridges between the different silos. Next, please. Yes, this one. We have some experiences, and Canada has most experience so far, and in the UK, you have also big data and many great studies now showing how you can start your own implementation process. And we try to publish that with the 3 country experiences in this paper, showing a stepwise approach to set up your own prehabilitation service. So this may inspire you at first, and if there's more questions, don't hesitate to ask more questions to us personally. Next, please. And going to my last slide. This is just a summary of the potential of prehabilitation. That's a multimodal, multi-professional, and multi-phasic program, making patients happier, making professionals happier by that, and making the healthcare program more efficient, and creating a window of opportunity to really make impact on the patients, their health status and lives, and to create and support them in an ongoing lifestyle change. So this is just a summary. You will receive this one, I believe, also by email, so you can have a look at it later in more detail. And this may help you to convince your system or board members to support you in implementing prehab. So I hope I've showed you our prehab experience and inspired you that this really makes patients happier, but also healthcare professionals. And hope to connect soon to share more of our experiences. Thank you for having me.
Steve, you're muted. You're on mute.
Sorry, I was muted. Sorry, Shalini. I say thank you, Stefan. You've inspired everybody and at least reminded us that we have to keep moving. If we could have the next slide, Shalini. And our final panelist today is Sandy Jack. And Sandy, would you like to share your experience?
Thank you, Steve. Thank you to the organisers for inviting me to talk at this prestigious meeting. We are a prehab family. We share very similar, if not the same views, and I'm equally as passionate as Franco, Steve and Stefan. Next slide, please. So I'm going to just touch on the evidence and the principles of prehabilitation. So there is emerging evidence. There isn't robust randomized controlled trials at present to give us cost-effective and effectiveness data, but hopefully they will be emerging in the next 12 months, potentially, with us reporting our trial and the Netherlands reporting theirs. What's really important is how we can better support patients. So it's supporting the patient, they're part of the team, we're all part of the team. Whenever we deliver the prehab interventions, either as a trial or as we've now moved on to a pilot service, we say to the patients, you have been diagnosed with a cancer, you may be undergoing neoadjuvant cancer treatments and potentially surgery. We're part of your team to support you through the process and to help you get fit for surgery and cancer treatments. It's really important that it's multimodal, as Stefan and Franco have already alluded to. That multimodal means that we have to look at the whole body system. You can't put out what you don't put in, so nutrition is really important, and you live if you want to live. So being psychologically prepared and reduce your distress levels is so important. When you're starting to think about surgery and treatment, so cancer treatment specifically, we've shown over the last 13 years that cancer treatments do harm as well as good, and that structured responsive exercise training alone can either reverse the effects of the reduction of your physical fitness or ameliorate if you exercise train during the cancer treatments. We have hypothesis generating data and a post hoc analysis to show that also exercise training may improve cancer outcomes. And there's some mechanistic understanding of what the harm of the cancer treatments may be. So in the context from my presentation, we started in neoadjuvant cancer treatments. And the questions to ask is why? Why do prehab? Who benefits from prehab? What do you do and how do you deliver it? When should you do it? And how can you bring the whole integrated care system together to deliver it as a system-wide approach? Next slide, please. So this is conceptualizing what both Stefan and Franco have talked about, showing this schema here about functional status, which is basically physical fitness, good nutritional status and psychological status, being independent and dependent. And on line A here, so it's pre-operative, then during surgery, and then recovery and rehabilitation. So the line A here shows that at baseline, you should have a stable baseline, and then following surgery, there's a hypothetical drop, which hasn't been proven yet, but some of our data has looked at that and others, so I'm sure this will be shown in the near future, following major surgery. And then without a complication, the trajectory back to normal is good, reasonably rapid, and that they go back to being dependent. What's really important in this diagram is this would map against any cost, effectiveness and effectiveness. And that when you start to see if there are any delays or trajectories back to normal, and what everyone has alluded to is that's all patients want, they just want to be back to normal and within 1 year, then you can see the cost implications. And this is eloquently demonstrated by B, where you've got the same patient who a stable baseline, and then they've had a complication and they never reach, they're never back to being independent. The costs here are the implications of increased length of stay, readmissions, care home, hospices, and the list goes on. So we can already see that if you're able to identify the patients that are more likely to have complications, this is a hugely cost-saving process. And then if you look at C, where you've delivered prehabilitation beforehand, and really this should be delivered during cancer treatments, because as I've already said, this drop here from surgery is also seen following neoadjuvant chemotherapy, chemoradiotherapy, and potentially immunotherapy. And you can see here that there's a significant fall, and then they have an increase in their physical fitness. So prehab, increase your baseline, less of a fall, trajectory back to normal far quicker, significant cost saving. But unfortunately, even with the advent of improved surgical procedures, patients still have complications. But if they have prehabilitation before the complication, then on line D, then they go back to being independent a lot quicker compared to line B. So mapping this against cost effectiveness actually is a good way to show your stakeholders and your funders how you can save money. Next slide, please. And again. So aerobic exercise should be prioritized because it's the only exercise training that has been shown to improve surgical outcome and cost effectiveness from a variety of studies that are listed here. So we and others have shown if you target a structured responsive training program that's HIT training, so it's high intensity training, you can improve surgical outcome, reduce length of stay, and it's cost effective. What's really important and emerging in the literature is nutrition is the missing link. So now these data in a meta-analysis and systematic review has shown the combination of exercise and nutritional support in small numbers of studies have a significant increase in improvement in surgical outcome. So much so that in the latest systematic review and meta-analysis by Waterman et al, they showed 2 to 2.5 days length of stay reduction. So what's really important is that we've also shown that you only need 3 weeks to do a HIT training program to get benefits. So you don't have to have a very long time. And also 7 to 14 days of nutritional remedial therapy also improves outcome, length of stay, and serious complications. Next click, please. What is really important, as I've already stated, if you want to live, you live. And we know that that state of mind is really important in survival and potentially recovery time. We have to tease out whether people have mental illness. So is it depression and anxiety, or is it just distress? If people have been given a cancer diagnosis and they know they're having cancer treatments and surgery, they're going to be distressed. And it's really important to tease out these, whether they have anxiety, depression, it's mental illness, or they're just distressed. And we can do this with the tools such as the distress thermometer. And also if patients have low self-efficacy, so they can't manage on their own, they just need support. And potentially even with just support, they will be able to go out to do walks and go to the gym, but they just need that support. And they've shown also that you can improve surgical and post-operative quality of life with psychological interventions. Next click, please. So we all wish that we had NICE guidance, which is the gold standard of guidance for any service or any movement forward within England. However, this is only present in lung cancer at present. Next slide, please. So what's the mechanism of harm? So poor physical fitness predicts adverse perioperative outcome. As we've already talked about, there's a surgical stress response, elevates tissue and organ demand for oxygen. So you can imagine if people are unfit, they cannot hit that demand. And also reduced lean muscle mass. So malnutrition is key, and sarcopenia is an independent risk factor of adverse outcomes. Also, cancer treatments cause the same effects of reduced lean muscle mass and sarcopenia. So malnutrition is key perioperative risk factor and severely undermining recovery, produces a profound catabolic state, and we really need to understand whether patients have got malnutrition or they're obese, but malnutrition is the key factor to be able to screen whether patients need a higher level of care. Next click, please. And I've already talked about the psychological traits, but we need to look at adverse mood states and be able to screen and assess for depression, anxiety, and distress. And if patients are seen to have any increased anxiety and depression, they should be referred to a dietitian. Next slide, please. So back in 2019, lots of people, Steve Wotton and Frank O'Carley and Stefan also contributed to the Macmillan guidance for principles and guidance for prehabilitation within the management support of people with cancer. Now, Macmillan are a cancer support centre in the UK. It's supported by the Royal College of Anaesthetists and the NHR Cancer Nutrition Collaborative. We sat together in dark rooms, deliberating and thinking about prehabilitation. And as Stefan's already said, it is a simple concept to patients, but it is a complex intervention. And what we found very early on is there is no robust screening and assessment tools. And you can't deliver cost-effective prehabilitation interventions and multimodal interventions unless you know who needs the highest level of care. We strongly believe that if we're able to screen and assess, we should be able to deliver low-level care to the people that are fit, intermediate level care for the people that are perhaps a little bit deconditioned, and high-level care for the people that are really frail and need to have further support. In that way, we'll be able to have a cost-effective process, which we should be able to convince our funders is the right approach. And it doesn't matter what level of care patients have, they should still have good outcome. Interventions should be multimodal, as we've already talked about, and monitoring and evaluation is key. We need to look at all of the monitoring evaluation and develop some core measurement and data and screening and assessment outcome measures to be able to deliver this in a more cost-effective and effective manner. Next slide, please. So this triangle here is from the NHS, so the National Health Service long-term plan that was devised to try and support patients across their life course. And we use this in our prehabilitation guidance. And at face value, it looks fairly simple. It's a triangle. And we're talking about universal, which is low level of care, and then targeted, which is a bit higher, and then specialist, which is the highest level of care. However, there's over 60 combinations of this triangle, because if you're looking at multimodal, so nutrition, exercise, psychological support, all underpinned by behaviour change, then you may be universal for your exercise, targeted for nutrition, and specialist for psychological support. You can move up and down of the triangle, and you can move around the triangle. What's really important is to try and identify who is universal. And in the UK population, this was prior to the recent disruption of all our cancer services. We think there's around 60% of the patients are universal, 30 to 40 are targeted, and 5 to 10 are specialists. What's the key factor of this is if they're universal, they may be able to have home-based, a virtual delivery of exercise and support in other community settings. Targeted again, they may be able to go to gyms, but also all this could be delivered in the community near patients' homes where they want these interventions to be delivered as a one-stop shop if possible. Next slide, please. So back in last year, we all sat together with a lot of our colleges in the UK, across England and the devolved nations to try and come up with some guidance, which has got significant traction in England and across the whole of the UK, to look at perioperative assessment optimization for adult surgery. So they looked at the fact that we should be establishing prehabilitation services. And I can tell you here and now from our trials that we've just completed early because of our interim analysis, and COVID blocked the fact that we couldn't continue, a large randomized control factorial design trial to look at the effects of exercise and psychological support. We then translated this rapidly into a virtual trial, and we will be reporting on those two trials very soon. But what's happened is that the trial that we call SafeIt, which was the virtual trial, supported patients during lockdown to deliver these interventions with an exercise instructor in a virtual manner. Now, this has now been taken away from certainly our geographical area because we've completed the trial. And so we've been asked as a call to arms by our Cancer Alliance, which they control the whole of the cancer funding and where it flows, that we set up a pilot service before Christmas. So we're actually trying to do that and trying to establish the services, all the caveats and all the issues that Stefan has talked about. We have a new integrated care system within England, which brings all together the community, primary care and secondary care. So from your family doctor to your hospice and your care home. And also there's money that NHS X, which are the digital component, thinking about how we can use apps, etc. Next click, please. And again. The key point that all our politicians have been grabbing hold of is that also exactly what Franco and Stefan said, these are preparation lists, they're not waiting lists. And we've got patients that are being cancelled a lot for their surgery, maybe up to 4 times. But part of the prehabilitation program within perioperative medicine and enhanced recovery is shared decision making. You saw that perhaps patients could undergo surgery and they'd never get back to being independent. As surgical regret, it should be a conversation with the MDT and the patients. Next slide, please. And again, so why? Good physical, metabolic and emotional status improves surgical and cancer outcomes. Who? All patients undergoing surgery and also cancer treatments. And it's translatable to other chronic diseases such as frailty, cardiac, kidney, the list goes on. What? It needs to be multimodal and most important needs-based. So we need to develop core outcome sets to be able to look at better screening and assessment tools. It should include exercise, nutrition, psychological support, all underpinned by behaviour change. So you can improve and support the patient to have long-term behaviour change and better outcomes. Next click. When very controversial because we have lists where we have to see a patient within a certain period of time. We don't think we should delay surgery in the fact that we're putting prehabilitation into the pathway, but we need to bring the whole pathway forward and ask the patients at suspicion of diagnosis that you introduce them to Stefan's absolute advocacy and Franco's that this is preparation and we're your team to get you fit. Next slide, next click. Where in hospital only if required and it's a medical need, community, home-based, virtual and hybrid. And one last click. Shared decision making with your multidisciplinary, interdisciplinary team with a competent workforce and the passion and belief that patients said to me, this is a double whammy of goodness, it saved my life. Thank you.
Thank you very much, Sandy, for that whistle-stop tour through a large body of information. And I think hopefully we've taken the opportunity to share the experiences of all 3 of our panelists. Whilst this has been going on, I've been looking at messages that are coming up in the chat room, and I'll come to those in just a moment. I'm aware that Stefan also needs to return back to clinical duties on the hour, so we mustn't keep him. So I just want to start with a general question to all 3 of our panelists. With limited time and resources, and I'm thinking that many of our participants are in relatively resource limited settings, how can we identify those most at risk? What advice would you give us? If anybody would like to kick off?
I can start. Absolutely, this is a crucial question. I think we need to screen the patient first. Okay, when I say the screening, I think we can use very simple things like for a fitness, let's say physical fitness or functional fitness, whatever. I think the Duke activity score index is simple. There are 12 questions and you will know exactly where you are. If you are over 34, there's an index. Generally, you are pretty good or reasonable because you're active, you function and so on. So there's different aspects. And I would say if you can do 2 minutes walking test or 6 minute walking test in a corridor, any surgeon can do that. Any oncologist can do that easily. It will take long. Otherwise, gait speed is another one. They're all of these are simple and they are actually, I would say, predict outcome to some extent in surgery, obviously. Now, when we come to nutrition, I think that is even simpler because there are 2 questions in the Canadian Nutrition Society or the MAST and MUST. Basically, they ask you, have you lost weight? Are you changing activity, health, eating habits, and so on? I think this is a little, especially in cancer, this is quite an important thing. If you do a screening, the psychological screening, I think we're using the HADS, anxiety depression scale, but you can use other things. The stress thermometer, very simple, that Sandy mentioned, 1 to 10, gives you an idea. Over 4, definitely there is a sense of distress. So I think this will give you an idea of screening. And then, of course, you identify your patients. And then after that, if the cutoff, definitely you go to the next one, which is full evaluation. I think this will be easy, cheap, but unless you have an idea how you're dealing with it, I would say start with that.
Sandy or Stefan, do you have anything you would like to add to that?
I agree with everything he said. We're using the same. Yeah, we're using the same.
I think the key thing to remember is that you need to identify what is required by the patient in order then to intervene for the patient. And I think far too often people have intervened without actually working out what the patient needs. So one of the key messages is a needs-led intervention, not something where you have a one-size-fits-all package which you roll off and introduce to the patients. Okay, second question. Are there any special considerations for prehab in oncology? So I'm thinking more in terms of non-surgical settings. Sandy, do you want to start with that?
So yes, Steve, I mean, you have to map the interventions with the ability of the patient to be able to adhere to the interventions. But we have shown that as long as you take it, carefully, that you can exercise train patients before, during and after cancer treatments. We allow the patients, if they, it's a trial, we're able to facilitate if they're not feeling very well, and we may reschedule, and they always want to reschedule their sessions. But actually, if you hit them hard at the beginning, so 3 times a week before, and then twice a week if they can during, and then ramp up again afterwards. As I say, we were concerned that perhaps we were doing harm to the tumor. We were causing the tumor to grow, but we very hypothesis generating, but certainly evidence to suggest that that's not the case. But just taking into account, and also really importantly, talk to your clinical nurse, your cancer nurse specialist, because they'll be able to advise you on what the treatments are and how you can integrate a prehab package within that the oncology pathway.
Thank you. Stefan, would you like to comment at all?
Maybe just one more suggestion, that we came up with a paper showing a multiphasic approach. So for cancer patients or intermittent or surgeries for metastasis, etc., there's an ongoing need to be fit during lifetime. And yeah, that's also good to be aware of, that being fit, or this approach, is not only just before or during treatment, but in your whole life experience.
Thank you. And Franco, do you have anything you would like to add there?
I think one of the issues that we find all the time is that working with oncologists, I hope there are oncologists in these sessions here, And I think sometimes we ask, oh, the patient is not fit to have chemotherapy or radiotherapy, but is fit to have a surgery. Hold on. I think I think we should really understand that chemotherapy and radiotherapy are a major impact, and I think we should start to even before them that and continue, like Sandy said. We generally promote very much that, but there is some sort of, and I understand oncologists are very preoccupied about the response to chemo or to radiotherapy and so on, so they focus on that. But I think sometimes we face patients who are very anemic and they are exhausted. And I tell you that from somebody, I mean, Steve will agree with me, in any nutrition parameters, if you can lose weight very fast, but it's very difficult to reconquer. It takes time to go back. So I think the key is to avoid loss of lean body mass. To me, it's all there. It's crucial. And that's where we can talk about nutrition later on.
Thank you. I just want to say that there's been Matthew O'Haran has posted once more and more information around diet and cancer. The purpose of this session is not to go into details in any one of those particular topics. We're very interested, obviously, in the iconic to better understand the nutritional considerations around cancer, and we'd be very happy to have another dialogue around that in the future. But I think it's very important to note that we can think about specific foodstuffs or special diets, but that can only be done when the metabolic demands for energy and nutrients are met. There's a great danger in pursuing individual foodstuffs or special types of diets, which of themselves may actually limit the ability of the patient to be adequately nourished. And the first priority is to ensure that the patient's needs for energy and nutrients are met. How we deliver that obviously is going to require particular care and attention from people who understand and know about these things and can develop a food-first approach and can then add to that with either specific supplements, oral nutrition supplements and the likes. But it's very important that we're not in this session trying to deal with the detail of that, but we'd be very happy to come back and do that afterwards. And if we haven't, I do apologize if that's what you came here specifically to see. Can I ask Stefan, just before I recognize he has to go, would you like to make one comment, Stefan? If you have a group of oncologists in the room, what would you like them to do? What's your take home to them?
Be creative and become a believer. Because if you believe, or if you are a believer and that you feel what fitness and functional capacity can do with yourself, and if you have seen it by just one patient, you will be a believer. And there's no issues with money or other things in organizations that are against it. If you show all the benefits on the value-based healthcare profile that I showed to any other people around you, you can really do it. When I started as a young physician, by having no money, we just created it by being believers and work together with the ones that know everything about the nutrition, the exercise part, etc. So don't hesitate to get in contact with us also after this talk, because we have many things to share, and we want to spread our healthy virus to all of you.
So thank you, Stefan. I recognize you now have to leave and go back to your clinical practice. So
thank you very much
for your time today on behalf of everybody who's attended. If we can just carry on some of these themes that came out in the Q&A. We've had several questions in and around the psychological or behavioral considerations. And in particular, there are questions around the extent to which we can now apply some of the science of behavior change and psychology in helping us structure these interventions. Sandy, do you want to start with a comment on that?
Well, contact Dr. Chloe Grimmett, I think, is probably what I would say. So I've learned a lot about behaviour change and how important it is. and that it needs to be embedded within the prehab pathway. And our colleagues are working very hard to make sure that's the case. I think the concept about distress is really important, and we have missed that out without their expertise. But I think it's certainly emerging, and it's on the lips of everyone that talks about prehabilitation now. You have to embed behaviour change so that you then get better longer term outcomes.
Yeah, I think there's two parts. I mean, Faith Martin, thank you very much for your comment in the chat, and I think there were a couple of others in there.
Sure, there are people experts.
But I think the critical point here is that there are two main things we're trying to better understand. One is, how do we activate parents, if you want, patients, if you want to include that expression? How do we help them to help themselves at a time of clear stress? And I like the idea around difficulties of acceptance and the likes. But there's also, can we actually encourage them to engage in long-term behavior change? So yes, you're absolutely right. And we welcome anybody who has any experience in this area to join in these discussions outside of this session.
I think, Steve, the only other thing that's really important is that the professionals, health and care professionals, are trained in behaviour change, and that's standardised across a system.
Thank you. Franco, do you have any comment around the psychological support and behaviour change?
Yes, sure. I think, we discovered the importance of, I would say we discovered, because the first study was very much on exercise. And then when we saw that actually 25% of our patients were actually depressed because we did the hats, then we said, hey, we scratch our heads and say, hey, you are missing here big things. And so there was anxiety, depression. So when we actually put on the bicycle, and we found that actually for a period of time in prehabilitation, these patients were actually, anxiety dropped dramatically. Okay, so there is an effect that we know from literature, there is an effect of exercise on anxiety. The question was, after surgery, the anxiety came back again. And this is because they are waiting for diagnosis. So I think the engagement is very important. And that's where we have this system where the patients we are screened, we identify that are in need, then they see, we have the two psychosocial nurses who actually do anxiety. They are expert in cancer, in majority, they've done years and years, and they guide the patient towards the engagement. But engagement also is important from the point of view, engaging them in this activity. So that means it's not only relaxation, visualization, mindfulness, but they actually be engaged and taking care of their body. Now, one issue is very important that we emphasize very much is the role of caregiver and the family. And I think that's, we always says, come together with it. And I think that's where, in my view, the engagement is supported by the caregiver. And I emphasize it, we shouldn't forget that. And I'm sure in oncology, this is very well known that. So on one side, we have the mindfulness and so on, but at the same time, the psychosocial nurses or psychologists, behavioral, is really engaging the patient in participating in this holistic aspect, because alone mindfulness is not really function to some extent where you have all the other components. That's where comes in the multimodal aspect, in my view. Body and mind and body. We've been talking all the time about this more and more.
One of the other, or a couple of people have raised questions in and around low and middle income country, so resource poor settings, where clearly we may not have the most capabilities or necessarily the most resources available. So what advice would you give to our colleagues in our low and middle income country?
Sandy, carry on.
Sandy, please.
Well, Steve, we did look into this, didn't we, about how we could do this. And we thought about making treadmills, not quite treadmills, but bikes and things in areas that are like the playgrounds, which we've seen in other places, so that you have lovely weather, so you can take the advantage of doing that. When we were trying to look at this, to set this up in Jamaica, we were very much focused on how we could deliver this to everybody at a very low cost, or in fact at a free of charge. And I think it's hugely challenging, But I think that it's certainly ambition that I know Steve, Alan and others have got, that we support this in lower middle income countries. So we'd like to talk further if that's possible.
I think the critical thing is that the principles apply,
Yeah,
but the context is different. And the question is the extent to which, given the local context and the local resources and opportunities, what can be achieved. And it may not be the same as what is done necessarily in Montreal or in Southampton, but it would still have an impact in one way or another. And the question is how can we work together to better support each other in acquiring this understanding so that people can take and apply it locally in their own contexts. Franco, is there any other comment you'd like to add in relation to resource limited settings?
Yes. I suggest that, it's always better to start with looking at what is the most common activity, surgical oncology activity, and you have around in your environment, whatever. This can be Kinshasa or can be Johannesburg and so on. And looking and identify the champions. You need some champions. If you don't have a champions everywhere, you cannot start. But champions cannot work on their own if they don't have a team. And I think you start like that, or let's say that probably hepatoma is probably the most common in Nairobi, something like that. And you discuss, maybe you try to understand that one, you probably want to address it. Just an example, or choriocarcinoma in Johannesburg or something like that. Because I did some work in Africa several years, so I understand more or less that definitely this could be something practical to address this one and see exactly what you can do. Remember, one of the issues very much in work, let's say low-income countries, is the distances. Okay, that you have to travel, you have to think about how you reach it and so on. Now, the technology today helps us a lot. So, I mean, everybody, I was amazed when I was in Rwanda that everyone has its own phone, and the phone gives you the how many steps you do a day. You don't need to go and special exercise. The people in low-income country walk a lot. They do kilometers to go and get the water. Just give you something. So I think that's, it's feasible, and it reminds me, an acid recovery surgery was the same thing. So I think that's they can do it. But we don't need very much. And I think the nutrition concern me in the low income country. And that's some adjustment that I'm not aware, and pain. That is a problem of alleviating pain in the low-income countries, a big issue.
Thank you. I don't know if you can hear coming through my microphone, but a storm has just suddenly hit where I am. There's a lot of noise. I hope you can still hear me. I intend to finish in the next 5 minutes or so. I have one specific question, and then I'll ask my speakers who remain to sum up. The question was from Gemma, where she says much of this evidence base relates to adult care. Do we have any understanding of pediatrics or children, teens and young adults in terms of this idea of prehabilitation?
Fortunately not. Not because I think we don't want to do it, just a question of focusing at the moment on the adult. But I agree that, we have to distinguish pediatric. I mean, probably we're talking about children. I know there is a group work with us on children. They did a tele-prehab with the children. And there is a group actually work with us, the children, and they, especially for with the leukemia. And so they were quite successful in actually do exercise with these children when they were there, and the family was, so there is something starting. I think it's a good sign, but definitely depends on the category, depends on the type of, the disease and so on. But definitely, I don't see why not.
Yeah, we're the same in a way. So introducing the concepts of prehab to our wider team and talking about it. We've got great advocates for teenage cancer that want to start to look at like using these interventions, obviously modified for teenagers. So absolutely, Franco, it's great to see that this would be translatable and transferable to that important patient group.
I think, again, it comes back to the principles and then applying them in context.
Absolutely.
And the rush to introduce these things requires some thought, some careful consideration, and some co-design with our patients and their families. Because if we can find ways of making this work better for them, then they'll be more likely to engage. I'm looking if there are any other things I've missed in the questions. I'm not going to go into all the details at the moment, but I just want to ask parting shots, take-home message from Sandy and then from Franco. Sandy, your take-home message to our participants today.
Take-home message is talk to your patients, get your patients on side, start to concentrate on this needs-based concept. Don't give up, because I'm telling you, it's the most rewarding thing that I've done in my life so far.
And Franco?
Yes, I think the patients love it. You know, they realize that, remember, you always have the one who are actually so enthusiastic, dynamic, they write to the collaborations committees and so on. And then you have the one who actually benefit, they say, and they come back to you after 1 month, 2 months and say, can I continue or something like that? And then the one or actually don't believe it is there. You have to accept there are always 5% who come later and so on. So I think definitely is a patient-centric, and that is holistic. And I think that to me is the future is very much preventative and not reactive.
Thank you. So we've covered a lot of territory today. We have a very wide and dispersed audience covering many, many countries. So can I start by thanking everybody for joining us today? If there are questions that you have that we haven't been able to address, please direct them to us. We'll be very happy to pick them up and come back to you where we can. It's clear that there's a lot of questions in the chat specifically about diet and nutrition in relation to not necessarily in the context of prehabilitation, but more in the context of diet or what people should eat before, during, and after treatment. And we'd be very, very happy if there was a desire there to speak with UICC about whether we can bring a future dialogue to you on that. This is part of a series of dialogues that we've set up with UICC. We've already done one on children, teens, and young adults. This is one on prehabilitation, and I think we'd be delighted if there was an interest in actually focusing specifically in and around nutrition and diet. I would encourage you to talk amongst your own teams about where this fits in your context. I'd be very pleased if you need any more information to direct you to publications by our panelists and as what Sandy referred to as the Macmillan Royal College of Anaesthetists and NIHR Cancer and Nutrition Collaboration Principles and Guidance Report, which was included in the flyer or the promotional material around this dialogue. Can I especially thank our speakers for joining us today, to giving up their time. They're very busy people, and we're very grateful for their contribution. And can I thank Shalini and Susanna and the team in UICC for making this particular dialogue possible. So I hope you all have a safe and happy onward journey in terms of the period up until the end of the year, and hope that in the new year it brings you every success and happiness. So thank you once, and goodbye.
Thank you.